welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
For our next presenter, we have Daniel Radev, who is a PGY2 EM resident at Rutgers Health, who will be presenting on personalized hemodynamic resuscitation targeting capillary refill time in early septic shock.
So to get started, the background for the study, sepsis and septic shock are very common disease states that we'll see in the ED and the ICU. And to summarize this complex disease, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection, while septic shock is a subset of sepsis, profound circulatory, cellular, and metabolic abnormalities. And using the sepsis 3 definition from the Society of Critical Care Medicine, it is also clinically defined as vasopressor requirement needed to maintain a MAP greater than 65 and a serum lactate greater than 2 millimoles per liter despite adequate fluid resuscitation. So looking at the current practice guidelines for sepsis, we'll use the 2021 Surviving Sepsis campaign. And specifically looking at initial resuscitation, they have the following recommendations as listed. So patients, they recommend receiving a fluid load of 30 mLs per kg in the setting of hyperperfusion. They also recommend using dynamic measures over physical exam to guide fluid resuscitation. They suggest using serum lactate as a marker for resuscitation, and they also suggest using capillary refill as an adjunct to other measures of perfusion. And it's important to note that all these recommendations, while they are commonly used, they all have weak strength in evidence and low quality as well. So it leaves a lot of gray areas in practice. So in order to better understand the ANDROMEDA-SHOCK 2 algorithm that we'll get into later, it's important to review early goal-directed therapy from the landmark trial by Rutgers and colleagues in 2001. This was a study that included adult patients who presented to the ED with severe sepsis shock and received early goal-directed therapy or standard therapy, and their primary outcome was in hospital mortality. So this is a flow chart that just summarizes the algorithm that they use in the study. So starting at the top left, patients received supportive care based on their oxygen needs and include intubation if required. And then for the next 6 hours, participants were monitored and targeted to meet several physiological targets. So fluids were given to maintain essential venous pressure greater than 8, and then vasopressors or vasodilators were used to keep the MAP goal between 65 and 90. And they also included red blood cell transfusions to maintain a central venous oxygen saturation greater than 70%. And they also used inotropes for additional support if that were needed to maintain these goals. If these goals were still not achieved through these interventions, then patients were then reassessed to see if they needed further sedation or escalate to mechanical ventilation just to further support hemodynamics. So the results of early goal directed and the reason why it was such a landmark trial was that it greatly reduced mortality when compared to standard of care. So this changed sepsis management by establishing early recognition and aggressive protocol-based resuscitation to dramatically improve outcomes. However, since the study, practice has evolved and it's not as rigid anymore from following this protocol. However, current sepsis management still retains foundational principles from early goal-directed therapy, primarily the prompt resuscitation with aggressive fluids, vasopressors, and antibiotics. So with a diverse condition like sepsis, is their standard initial resuscitation always appropriate? One important question is whether aggressive fluid administration can actually cause harm. So looking at a 2016 systematic review of meta-analyses by Silversides and colleagues, suggested a more conservative fluids were associated with more ventilator-free days and shorter ICU stays. And then in 2022, the classic trial by Mayhoff and colleagues showed that restricting fluids did not reduce death when compared to standard fluid therapy. So it reinforced that fluids can be safely limited when patients do not show clear signs of hyperperfusion. And overall, these findings are some of the few studies that support the more individualized approach to fluid management and may be more beneficial than applying a one-size-fits-all. So further challenging the current standard of care, specifically using in terms of lactate to guide resuscitation, The first ANDROMEDA-SHOCK trial by Hernandez and colleagues evaluated whether capillary refill time could be used as a target for resuscitation. So the study enrolled adult patients with septic shock, and all patients received the same protocol. The only difference was the guiding target. And the primary outcome was 28-day all-cause mortality. So this is another flowchart summarizing the protocol that was used in the study. So starting at the top left, patients were assessed either with their CRT or lactate, depending on which group they were in. If the value was abnormal, their fluid responsiveness was assessed, and IV fluid boluses were given 500 cc's every 30 minutes. If on a reassessment, if their CRT or lactate was still abnormal and the patient had a history of prior chronic hypertension, the norepinephrine was titrated to reach a MAP goal of 80 to 85. If CRT or lactate was still abnormal after these steps, patients then received a low-dose inotrope such as dobutamine or milrinone, and the total protocol was followed over an 8-hour period. So the primary outcome showed a numerical 10% mortality difference, but it was not statistically significant, as well as the secondary outcomes also did not reach statistical significance. And overall, the authors conclude that CRT did not reduce all-cause mortality compared to lactate, but its findings suggest that CRT is at least comparable to lactate as a resuscitation target. However, the clinical application for using CRT after the study came out was challenging since both groups received nearly the same protocol, so it limited the ability to isolate CRT's true effect. And then these limitations helped motivate their next study, the ANDROMEDA-SHOCK 2, which is the main focus for today. So going into the methods of the trial, it was a multi-center randomized controlled trial conducted in 86 ICUs across 19 countries, primarily in South America and in Europe, and it included around 1,500 adult patients with septic shock. So the authors defined septic shock in the study as suspected or confirmed infection, hyperlactatemia, as well as the requirement of norepinephrine to maintain a MAP greater than 65 after an IV fluid load of at least 1 liter. And the enrollment window for patients was 4 hours from when they met the inclusion criteria. So here are a few exclusion criteria that I'll highlight. I'll highlight the first 4. So patients were excluded if they were greater than 4 hours after their onset of septic shock. They were excluded if they had any anticipated surgeries or dialysis in the next 6 hours. And then patients with refractory shock, which the author stated that clinicians that were treating the patients decided whether they were refractory, didn't necessarily follow a specific guideline, were excluded. And then patients where CRT could not be accurately assessed were excluded. So those patients that had peripheral vascular disease, hypothermic patients, patients with darker skin tones, or patients with Raynaud's disease. So looking at the intervention, patients were randomized to receive a 1-to-1 ratio to receive a capillary refill guided personalized protocol versus usual care. And usual care is defined as patients treated to the local protocols or any international guidelines, such as the CCM guidelines, based on the hospital that they were in. So the algorithm was divided into 2 main tiers, and the entire algorithm was applied over a 6-hour period. So this slide here just shows the tier 1 interventions. And if we start at the top left, patients with a normal CRT, they were not giving any interventions until that CRT became abnormal. And once CRT was abnormal, the first step was to assess for pulse pressure. If the pulse pressure was less than 40 and the patient was fluid responsive, they received a 500 ml fluid bolus with the option for 1 additional 500 ml bolus. If the pulse pressure was greater than 40 or they weren't fluid responsive, norepinephrine was titrated to reach a diastolic arterial pressure of at least 50 or more. And if the patient's CRT did not improve after these interventions, they progressed to tier 2. So tier 2 is where they have their more advanced intervention. So it began with a basic echocardiogram to evaluate for cardiac dysfunction. And patients that were found to have cardiac dysfunction were given general treatment recommendations, but they were not required to follow a specific protocol. And then if cardiac dysfunction was not present, the next step was to assess if they're fluid responsive still. And then patients that were still fluid responsive received additional fluid boluses until the CRT normalized. If the CRT remained abnormal or giving further fluids was harmful for the patient, the next intervention depended on their history. And much like in Andromeda 1, if patients had a history of hypertension, the MAP challenge was performed by increasing norepinephrine to a MAP of 80 to 85. And if their CRT improved after that MAP target, the MAP target was maintained for the remainder of the protocol. If CRT did not normalize after the MAP challenge, the next step was to initiate a fixed low-dose dobutamine trial that lasted for 1 hour. If CRT improved, then dobutamine was continued for the rest of the protocol. If it did not normalize, then after all these steps, then clinicians would proceed with rescue therapies at their discretion. So looking at the endpoints in the study, the primary outcome was a hierarchical composite outcome, which is when multiple outcomes are grouped together and ranked in order of clinical importance. In this case, the outcomes assessed at 28 days included an all-cause mortality as the highest importance, duration of vital support, which included any vasoactive medications, mechanical ventilation or kidney replacement therapy, and length of hospital stay. Secondary outcomes were individually tested in a hierarchical order, which included all-cause mortality, vital support-free days, which was the number of days in which patients were alive and not requiring any cardiovascular, respiratory, or kidney support, and then length of hospital stay as well. And looking at the statistical analyses used in the study, the primary outcome was analyzed using a stratified win ratio method, which I'll go in more depth in the next slide. For secondary outcomes, a gatekeeping procedure was used, and gatekeeping is a statistical method that tests multiple outcomes in a predefined order and stops testing as soon as one outcome is no longer significant. And then for confidence intervals and p-values, a bootstrap resampling method was used, which is a statistical technique that repeatedly draws samples from the original dataset with replacement to estimate the variability and reliability of an outcome or effect. So the win ratio method that they use in the study works by comparing every possible pair of patients between the two groups. So for each pair, the patient is classified either as a winner, loser, or a tie. So for example, in the study, the top ranked outcome was all-cause mortality. If the patient in the CRT group survived and the patient in the usual care group did not, then the CRT patient is classified as a win. If both patients survive, then the next outcome on the hierarchy is compared. And then after all of these possible pairs are assessed, the total wins for each group are totaled and divided to create the win ratio. And to interpret the ratio, if it's equal to 1, there's no difference. If it's greater than 1, then treatment group superior, and less than 1, control group superior. So going into the results, reviewing the baseline characteristics, I'll highlight a few points that stand out. Among patients with the confirmed infection, an intra-abdominal source was the most common source. And additionally, the time from meeting septic shock criteria to randomization was approximately 2 hours in both groups, indicating that these patients were enrolled very early on in their septic shock course. Further, in both groups, all patients were receiving norepinephrine, and majority of patients were intubated, and both groups received around 1.5 liters of fluid prior to any study interventions. So moving on to the primary endpoint, this table shows the total number of wins in each group. So the CRT group had a total of 131,131 wins, while the usual care group had 112,787 wins. And this resulted in an overall win ratio of 1.16 with a p-value of 0.04, which was statistically significant. So this means that comparing patients pair by pair, CRT was associated with more favorable outcomes across the hierarchy than the usual care. And the authors stratified their primary endpoint by their Apache 2 score. So by looking at patients that had an Apache score less than 19, there was only a small difference in mortality wins between the two groups. The biggest difference appeared in time to cessation of vital support, where their CRT group had 47% total wins compared to 37.8% in usual care. However, when all the components were combined, the overall win ratio in this subset group did not reach statistical significance. Looking at patients with higher Apache scores, mortality once again did not difference greatly between the two groups, and the primary notable differences were in the time to cessation of vital support, where CRT group had 49.9% wins, and then 39.5% in usual care. And then when all the components were combined, the overall win ratio was 1.22, which was statistically significant. And then looking at the secondary endpoints, the 28-day all-cause mortality was almost identical between the two groups, 26.5 in CRT and 26.6. So it did not reach statistical significance. And therefore, since the primary did not reach significance, the rest of the endpoints were not tested for significance as well. But it's important to highlight some key numerical differences. Specifically, I want to point out the length of hospital stay, which was averaged around 15.3 days in the CRT group compared to 6.2 days in the usual care group. So the authors conclude that among patients with early septic shock, CRT protocol was superior to usual care for the primary composite outcome of mortality, duration of vital support, and length of hospital stay. They note that it was primarily due to that shorter duration of organ support. So some strengths of the study is that it is a prospective randomized controlled trial, which is a gold standard for clinical research, and also the use of clinically meaningful outcomes, particularly mortality, which also adds to the relevance of patient care. And since the study was a multi-center trial that included academic and community hospitals, findings are more generalizable to a range of healthcare settings. And then another important strength is the use of accessible tools within the protocol. CRT is inexpensive and easy to perform, can be useful in resource-limited settings. And then some limitations is that it is an open label design study as well, so both investigators and participants were aware of treatment allocations that could introduce some biases, such as detection and reporting bias. And then another key limitation was exclusion of patients who could not have CRT accurately assessed, specifically patients with darker skin tones. Although this is a small percentage of patients in the study, this significantly limits its feasibility in many institutions, specifically across the United States, where we have more diverse patient populations. And while CRT is an expensive tool that they used in the algorithm, the whole protocol itself was resource intensive, meaning that it required frequent hands-on assessments, and this can be difficult to implement in busy emergency departments, especially in the setting of staffing shortages across the country. And regarding the composite outcome, while composite endpoints can increase statistical power, they may also dilute the clinical relevance of the results. So in the study, the primary composite was mostly influenced by the differences in the vital support rather than mortality. And then although the win ratio also helps increase statistical power, it does not also translate into a clear, easy interpretable benefit for patients or clinicians, and applying it to a day-to-day practice can be challenging. So in conclusion, ANDROMEDA-SHOCK 2 adds to growing data that a one-size-fits-all approach to sepsis may not be appropriate given that the disease state is very diverse. It adds support to implementing strategies to sepsis care that target dynamic measures like fluid responsiveness, which can help prevent overtreatment and harm to patients. However, the algorithm is complex and its use is not validated across patient backgrounds, specifically such as race. It limits its feasibility of a CRT protocol being adopted as standard of care, and future protocols should be studied that maintain principles like fluid response challenges and frequent perfusion assessments. And that's all I have for today, and I'll open the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.